So it sounds like you know a lot about Tinder.
I know nothing about Tinder.
I'm sorry, just trying to keep you on your toes, but I've never used that. So I was just really curious. Did you meet your wife on Tinder?
I did not. This is far. The person I jumped out of a plane with is now my wife. So
really?
Yeah. It was pre-Tinder.
Were you guys in one of those tandem things where you were jumping together?
No. But unlike today, where it was just me, the mistake I made back then was like letting her go first and watching her, plummet to potentially her death. But it didn't actually happen that way. It was like, wow, that was the scariest part of jumping out of the planes. I'm glad I didn't have that today.
So you jumped out of a perfectly good airplane.
Perfectly good airplane. That was the website where I found perfectlygoodairplane.com.
Is that right? Yeah. That's amazing. I love that. All right, well, welcome. We are on episode 27 of Boombostic Health. We're doing another Boombostic Health in the Wild, our second of two here at our Healthcare Innovation Summit, Day 2 in Indianapolis, where Day 1 we were at the Indy Motor Speedway and enjoyed a lot of fun with our friend Jack Harvey in the number 24 car. And we have some really important folks that are here visiting for this conference, and we did a drawing out of a hat. And two lucky individuals were able to get a ride in an Indy car going pretty fast, as I understand it. And one of those is my friend here, Matt Honan, who's a member of the Boombostic Health community now and also serves as the VP of Corporate Development at Sonic Healthcare USA. Welcome, Matt.
Yeah, thanks for having me on the show. And forgive my very casual nature here. Just got out of the 200-mile experience.
Yeah. Half the time I wear a tuxedo T-shirt. You're good. Actually, the other day I wore my HAL 9000 T-shirt,
nice,
which I'm told makes me look particularly cool, if you consider being a total nerd as being cool. But have you seen the movie 2001: A Space Odyssey?
I have, yeah. It's been a while.
It's pretty prescient, and you should rewatch that thing. So anyway, well, Matt, first of all, thanks for being here from all the way from New Jersey. And thanks also for being a great partner. We've, at my company HC1, been working with Matt's company, Sonic Healthcare, for, about a decade, I think. And it's been a fantastic partnership. And we've learned and grown a lot together. And we're growing a lot more together. And so we're going to mainly talk about what the opportunities are with laboratory from a growth perspective and how you can go about it with a data-informed strategy. And I think we'll venture off into a few different areas. But before we get there, just tell us about this experience of going in the IndyCar. Like, just really quick. We all wanted
very
to do
quickly.
it.
It was, I'd say, the top two coolest experiences of my life. The other being jumping out of a plane. It was that intense.
Really?
Yeah. You're hitting these turns and the G-forces are literally squashing you up against the side of the car. You know, your helmet feels like it's literally going to get ripped off your head. It was
so this is it's an open wheel car.
It's a legitimate Indy car, just with a second seat in the back.
Okay.
And
and then did you help give the driver any pointers at all?
He didn't take them from me. He similarly had glasses on, so I said, all right, well, he can at least see. And
you hope.
I said, if I need to get up there, you just, give me a tap on the back. I'll get up there and drive. They said we were getting up to 200.
No way.
On video, I looked at the video back, and it looks relatively slow. But I can promise you it was not slow.
Like the Cheech and Chong movie where Cheech gets pulled over and the cop says, do you know how fast you're going? And he says he doesn't know, and he's like, you're going 16 miles an hour. And then he kept asking him for his driver's license, and Cheech kept going, isn't it back there on the bumper? Anyway, that's a whole, Ken Cerny, who many of us know from LabCorp, he actually ran into Cheech and Chong in New Orleans when War College was going on and got a selfie taken with those guys.
Oh, yeah.
Which is pretty wild. So I don't know. It seems like all the weed has been working out fine for those guys. But anyhow,
Well, I'm glad I got the IndyCar experience. I think that would trump Cheech and Chong for me. And
for sure,
yeah.
no question. Yeah, I that makes sense. All right, well, appreciate you being here.
Yeah,
on
happy to
topic,
be here.
and I'm glad that you survived the race car, and they'll probably try to recruit you to come be on the circuit next year.
Of course, yeah.
Maybe we'll sponsor you instead of Jack next year. All right.
I'll take a discount.
Cool. All right. Well, so diving in, you've got a big opportunity and you come from a background in healthcare. You've had some experience. Start out just why are you in healthcare? How did you make it into this space? And what are you thinking, you know, the next steps are for you to innovate and bring the value of healthcare to more people?
Yeah, no, it's a great question. I actually started off in a career track, if you will, that was much similar to what I just experienced out there in Indy Motor Speedway. I was a mechanical engineer. I was doing industrial engineering for automotive and aerospace applications. Actually got, you know, the ability to have a department, a P&L and all that, and didn't even know what P&L stood for back then, honestly.
Did you guess? Did you hazard a guess?
The boss put it on my, he's like, this is your P&L. I said, what's P&L? He's like, manage to this. And I said, okay. And then, you know, as I got further into that, realized that, you know, the business side of what I was doing was much more interesting. So I left engineering, got an MBA, long story short, interned at a company I think we've all heard of, Quest Diagnostics, and realized, you know, engineering and manufacturing and industrial, you know, aspects of that was very akin to the lab world. And it was all about scale, right? And building efficiency. And as many of us do, we all have, you know, family members that have been impacted by, you know, whatever it may be, cancer or other diseases. And so you start to, even in like finance, M&A, corporate development, you start to really have the ability to help change outcomes, change lives. And, you know, something I feel, you know, very strongly about is lowering the cost of healthcare. And making it as affordable as possible, and scale, for example, is kind of one way to do that. So over the course of the last 10 or 15 years, really had the ability to put my fingerprint, even in a corporate dev setting, to have that impact on the space.
So there are a lot of partnerships that have happened over the years between independent commercial labs and health systems.
Yep.
And some of those have had good results, some of them not as good.
Sure.
Do you have any thoughts on what is the recipe to make that kind of a marriage go really, really well?
I mean, I think you just hit it on the head. It's a marriage, right? It's not a I don't know the experience, but Tinder like swiping type of.
It could be. We could add that. We could add, that's maybe the app we should create. Every health system and every independent lab could swipe. You could have profiles.
Yeah, there you go. So it is a marriage, and it is something, one, you have to work at. I'm in one myself, right? It's not easy. You got to be open in terms of communicating all that. I think the recipe is still evolving, right? Even though there's been dozens of these that have happened in the last, 10 to 20 years, finding the right fit for on behalf of the health system is critical. I mean, whether it's, my current employer, Sonic, Quest, LabCorp, whoever it may be, like everybody kind of has their own spin to how they view lab and how they think the relationship or that marriage should work. So cultural fit, I think, is a huge piece to finding kind of a successful relationship there. And really,
healthcare is really local. Healthcare
is super local, right?
So maybe that's part of it. One of the things I've seen work well is when you can keep the clinical leadership local, and make it so that those individuals are empowered, more resources, versus pulling out all of the talent, putting it somewhere else. It's kind of like when you go to a bank and you need a loan for a business, and they have to call somebody who's in a city that's 1,000 miles away to get an approval, who's never met you, doesn't know anything about your business. I think that's a similar thing in healthcare sometimes when you have these arrangements that take what was local and make it so it's remote.
Yep. No, absolutely. I mean, the people at we're still, even in the world of AI and automation, in a very people intensive business, right? So like if the people aren't, happy with the relationship and motivated to continue to drive it and really have skin in the game, I think, you see these relationships and on paper they look like an outsourcing, right? But like the ones that really succeed, the ones that do well, are anything but outsourcing. It's very much a strong partnership there. I think, even in the couple of months I've been at Sonic, for example, we've walked from a few things because we're not as local as I feel we need to be to really deliver flawless execution. So like when you think about what relationships are out there in the market and in the space, like being closely knit in the community, having the right presence, within a very reasonable geography is paramount to actually being able to deliver day in and day out, and not have hiccups. So you really do need to have that as a priority.
Right. So it sounds like you know a lot about Tinder.
I know nothing about Tinder.
I'm sorry, just trying to keep you on your toes, but I've never used that. So I was just really curious. Did you meet your wife on Tinder?
I did not. This is far. The person I jumped out of a plane with is now my wife. So
really?
Yeah. It was pre-Tinder.
Were you guys in one of those tandem things where you were jumping together?
No. But unlike today, where it was just me, the mistake I made back then was like letting her go first and watching her, plummet to potentially her death. But it didn't actually happen that way. It was like, wow, that was the scariest part of jumping out of the planes. Man. I'm glad I didn't have that today.
So you jumped out of a perfectly good airplane.
Perfectly good airplane. That was the website where I found perfectlygoodairplane.com.
Is that right? Yeah. That's amazing. I love that. That's amazing. Well, I can tell you're an innovator. You're willing to take some calculated risk, and as long as you have the chute or a professional driver, you're good.
Yeah, there you go.
Okay, sorry. I just had to ask that question. I was curious. So getting back to the topic.
Yeah.
So in terms of the growth opportunities, when you've been with these labs that are commercial labs, and you've seen a lot of growth, and is there and you talked about being local and being able to integrate, like how do you, as you think about scaling a diagnostic service like lab that is so integral to care delivery, and then that the culture has to be right and all these things, how do you use data to target where you should do your outreach, or who?
Absolutely.
How should we think about that, and what does that look like?
Yeah, I mean we're all living in a world, right, where reimbursement's doing this, and it's likely to not change, right? There could be some steady state, hopefully, but like you really do need to drive the cost side of the equation, and or just building volume growth. Talked about growth, so like I use data, for example, in a number of ways. Around leakage, for example, right? Like a hospital wants to keep their business. They want to stay in lab. They know how critical it is for care delivery, but you've got, 30, 50, sometimes more % of your doctors going elsewhere. How do you tell the right story to say, let's keep this in the family?
So this is 30 to 50% of the doctors are ordering testing from somebody other than the lab that the health system has selected.
Yeah. Or, if the hospital has a robust outreach program that's competitive with a commercial lab, why are they going to the commercial lab? Why aren't they sending it internally? Some of that is around patient access, right? So like, what are the right touch points in the community to draw blood or collect specimen? How do you do that in a really thoughtful way to drive not only productivity, but just having the right community aspect and ensuring you have every community served? That's a big part of it. And then how do you craft the right messaging? Whether it's commercial, IT, turnaround time, it all matters to that physician to say, hey, look, we have the right offering right here in your backyard.
So some type of scorecard, but also for the physicians to see that this is the best for them.
Yeah.
But also the leakage analysis you talked about, is that all based on the claims? Do you pull like healthcare claims and run the analysis to see what's getting sent somewhere else?
Yeah, you can get pretty granular at the test level, right? And some of it could be payer driven, but more often than not, it's hey, this lab's in my drop down, let me just do that. Or I hear more often than not that the provider may actually have the patient's wallet in mind when they make that decision, right? So they say, I love my health system. I may be employed by them, but they may actually charge $2, $3, $4, 5 times the amount that a commercial lab will. So like, why do that to my patient? And I think there is, certainly justification for many of the health system, payer rates, of course, that are out there. But at the same time, there's also a middle ground to be struck. And I think, having that payer aspect out of the clinician's head is a way to help kind of steer that leakage, if you will.
Right. So getting into more of the impact lab can make to predict and prevent and get ahead of the curve so people are treated more effectively, more proactively. I know that there's an example with CKD that has been effectively implemented actually by Sonic. I remember there was a case study about that. And it seemed like an interesting start to a journey that a lot of those kinds of playbooks could start rolling out. And we haven't seen as much of that happen yet. So I'd love to hear from you about how do you get a health system to, in a health plan, I guess in this case, to leverage the insights in a more, I'd say, powerful, impactful way than just, hey, this patient at this point has already been diagnosed, or we find out that they have CKD because they crash and end up in the emergency room. Can you talk a little bit about what is that playbook to be more predictive? And then how do you envision plugging that into healthcare delivery so that the lab is more strategic in helping to prevent these terrible things that are costly and obviously also harm the patient?
Yeah, absolutely. I mean, that's a big part of the value prop, I think, in working with a laboratory that does this all day, every day, right, is to bring those insights and those analytics around, whether it be CKD or other chronic diseases, to say, hey, whether it's your health plan or just the provider network in general, let us create this feedback loop for you to say, there's obviously your health plan is probably top of mind when they think about that, but there's ways to really leverage the tools that we have around population health to really steer and manage outcomes in a more efficient way. And like you said, the criticality of having that embedded data in a way that's easily digestible. I mean, we were talking about yesterday, right? All clinicians are bogged down with however many things throughout their day. Like, it needs to be seamless, and it needs to be, interoperable, whatever the term may be. So we're working strongly with partners like HC1, for example, of how do we embed the analytics and the insights in a way that's as digestible as possible, and in a way that really provides actionable, real-time ability to manage care.
Yeah, it's interesting, the example of identifying the need, but then having it somehow prompt action, some kind of intervention. That's the last mile that matters, that delivers on the value proposition. I know one of the examples of that I've been really excited about that was created by our team is focused on anemia specifically. And not many people realize this, but a substantial double-digit percentage of people who go in for surgery are actually anemic.
Yeah.
And as it turns out, that's a significant complicating factor in their outcome. And so if you have to transfuse them to solve the problem immediately,
sure,
that's a liquid organ transplant. And it introduces a lot of potential risk. It's obviously a lot of cost as well. And so in this case with anemia, there's actually a connection into all of the scheduling for all the patients that are going to be having surgery, or whichever segment of the surgery population the health system partner wants to focus on.
Yeah.
But then if you think about how somebody's anemic, it's based on a laboratory test.
A very simple one too.
Very simple one.
Yeah.
And so you can run that test. You can find out proactively with enough lead time that they can then have an infusion therapy, which actually is appropriately chargeable service by the healthcare provider. So it generates revenue instead of just being a cost on the blood side, and it makes it so the patient outcome is much better. And that's just a simple example of how lab and the insight from lab gets integrated into care delivery more broadly. And to zoom out, I have been on this giving speeches all across the country and looking to try to get people to focus on this bigger picture of what is healthcare really about. And it's really about longevity. It's about living the longest life that you can and as healthy as possible. And in order to do that, we've got to start being more preventative and more proactive. And we've got to also start connecting the dots between these different areas. Lab insight can actually transform the way all of healthcare gets delivered. If you just focused, if you think about this question of there's so many things you could do, but what's the one thing that by doing that thing, it makes everything else easier or unnecessary? Mm-hmm. I would contend that implementing a strategic program that's truly integrated with the lab across all of care delivery, you start to realize some major, major benefits. And I think about the example of CKD that we talked about as a tip of the spear, but let's think about a longer range issue of cognitive decline and all the people that are developing Alzheimer's and the fact that you now have medications that can slow that progression.
Sure.
Do you see a future where it flips from the lab being something that is relegated to it's in the basement or how cheap and how fast can you give me a result, to where it's actually a strategic focus and something that everybody at the C-level and in the health plan and beyond are saying, this is one of the key parts of our strategy. How can we optimize this? Yeah. It's going to make everything else better.
Absolutely. I mean, I think it has to shift there, right? Like we talked about reimbursement a little bit, like it can't purely be looked at as a cost center, even if it is, a cash flow generating entity. The insights that are driven from lab are just so critical and essential to 70 to 80% of any clinician's decision making. Like, how could it not? So I feel like everybody gets that personal experience, some more than others, where like a lab test actually changed how you were treated or an outcome. And for me personally, and has nothing to do with any of my employers, like looking at longitudinal data across a variety of different tests over time, you can just at a very granular level see where things are trending and where things need attention. And you can, like, our clinicians always have patients top of mind, but they see lots of them, right? So you do need to be an advocate for your own health, and lab is, I'd argue, the best way to do that. So, as more and more people become aware of insights, you've got a strong push towards, high deductible plans. People take more of their healthcare now than they have previously into their own households and their own wallets. I think moving from a cost center, a P&L to a data centric way of driving behavior. I think that starts with maybe the health plans that are owned by health systems. I think that's a great place to start. I think we've been talking about, ways to embed quality measures and quality outcomes from, those health plans as a way to drive, favorable moving forward. But I think it's a path that we absolutely have to be on. It's kind of like AI and other ways to be efficient. It's an essential. It's not just a nice to have at this point.
Well, I know that we have a lot of folks that are here that are focused on how to grow their lab businesses and where they can go to really move the needle on healthcare. And I think in the case of Sonic, which has been a great partner of ours at HC1, you guys have kind of a unique approach relative to some of the other major players. Could you just touch on that? Because I've seen, like, nobody really knows. Sometimes when I say that we're working with Sonic, people ask me if we're getting burgers over there. I mean, it's an incredibly big organization that is very under the radar, relatively speaking.
Yeah, very much.
Because that's kind of by design.
It's kind of by design.
Yeah, how's
in
that?
Some ways.
Talk about that a little bit, because it's pretty.
Yeah, cool. I mean, we operate a model that's not pushing the Sonic brand necessarily in every single market. We have a federation of brands, for example, and a way that allows us to deliver healthcare, like back to the beginning of the conversation, at a much more local decision making, local laboratories. When you get in front of a client or a physician, whatever it may be, those are the decision makers in those markets. So it does allow us to be a bit more nimble. You talked about burgers. When I told my mom I was moving to this role, she said, like, the hedgehog, like, and I was like, not quite.
That's a good one.
So yeah, we go about it. We go about going to market differently. Period. I would say we take and also a different approach to our health system relationships. We have a number of very long-standing joint ventures. That's in many ways the preferred model because it does keep both parties very incented. There's skin in the game on both sides. You have joint governance. A lot of these aspects can be done in lots of different structures, but at the same time, the mutual ownership and operational aspects of driving the laboratory, you need that alignment, and I think the joint venture helps do that. So, having been at another buyer, if you will, I think the approach here is certainly very collaborative and very very intentional about finding that mutual cultural fit to say, we're not the right lab for everybody. I also have a pretty strong view that not every lab, should be sold or should be partnered. Some of them are doing awesome work and have really figured this out. And why come in and meddle with that? But many health systems, especially coming out of the pandemic, they have a need, right? And it's not just laboratory. They think about how do we partner in ambulatory surgery or imaging. It's not uncommon to go out and say, hey, this company does this all day, every day. Why wouldn't we leverage their expertise? And that's the model we find most effective.
So to play it back, it's about partnering with existing practices that have pathology capabilities, that have laboratory capabilities, and you can bring some additional value to help them perform more effectively. Yeah. But it's not all about just efficiency. It's not just, hey, how do we go take their volume, add it to our volume? We've got more volume so we can squeeze costs out. It's about making healthcare local, but powering it so it's more effective because of the value proposition that a larger organization can bring. Is that fair?
Yeah. I mean, there's some low hanging fruit there, right? Around purchasing power, right? We buy probably hundreds of millions of dollars, if not more, in the US, and then much more than that globally. So to go to an IVD vendor, for example, with that purchasing power and the ability to help a health system do it that way, I know HC1 does similar work there. There's so many things that are table stakes, and then you get into things like population health and the ability to close gaps in care. It could be payer dynamics as well. There's so many attributes that you can really kind of plug and play in a relationship. And I think our perspective is, and not uncommon to say, you've seen one, right? You don't want to come in with a cookie cutter, kind of this is how it's always been done approach. And we have the ability, I think, because of the way we operate, to really craft, a mutually beneficial strategy for how to go make the lab more efficient, but also grow.
Okay, really important question as we're rounding the corner here. Pacers, Knicks.
So I live in northern New Jersey, and my allegiance is actually not to the New York team. So I'm going to go with the Pacers on this one.
Thank God.
Yeah.
I'm so glad we can still air this show. He's going with the Pacers. Did you hear it?
I got Pacers.
Awesome. I appreciate that. Well, I'm so glad you could be here for this episode of Boombostic Health. Also, really glad you were able to participate in the Healthcare Innovation Summit, and you got to.
It's been awesome.
I feel like I lived through your experience in the car. Thanks for giving such a visceral recount of that, and glad you survived that as well. Thank you so much. Look forward to continuing our great work together. And
absolutely,
thanks to everybody for being here for another episode of Boombostic Health. We'll see you next week. And thanks to Matt for being a good sport about the Tinder questions.
Quick introductions, although I suspect most people know us by now. My name is Crystal Contini. I chair the Mergers and Acquisitions Practice Group at McDonald Hopkins. I am joined by my lovely colleagues, Liz Sullivan, who chairs our healthcare practice, and Emily Johnson, a partner in our healthcare practice as well. We have been accused of talking about the same thing at these conferences. And so we are going to try to have a little bit of a different slant, because the world of M&A is very vast and we could talk about just about anything. But I think because of this focus of this conference, I think one of the very common themes has been around data management, supply chain management. How do those things play out through an M&A context? And I think a lot of the discussion around this last couple of days has been, okay, if you have the right tools in place, you can continue to keep your laboratory operations in-house, manage them efficiently, appropriately, deliver great client care. But there's also the possibility you decide, okay, well, maybe, my core competency isn't running a lab. And maybe I want to go out as a healthcare system and say, how about I have someone come in and either manage the lab for me, or maybe I sell my lab. The question becomes, what exactly are you selling? And for a healthcare system, it becomes, it's not as intuitive as you think about the different streams of laboratory revenue. So one of the conversations we often have at the beginning of a process when our client is considering either to enter into a management services arrangement with a third-party provider or to sell their lab is to talk about what type of laboratory revenue are we actually talking about. And so this is where we get into this compliance regulatory focus of what are the revenue streams. And so I'm going to make my colleague Liz kind of describe the revenue streams that we often look at, and then we'll talk about what it means to potentially monetize them in the M&A context.
Thanks, Crystal. So yes, as we were kind of brainstorming, as Crystal was brainstorming for this, we were talking a lot about the fact that we have gotten into situations before where, there isn't a clear distinction between sort of the inpatient, outpatient testing that an organization is doing and sort of their outreach business. So they might not have a good handle on like what is outreach versus what is the lab volume that's really being generated by their patient population. And so we've actually run into a couple situations where we've had to try and assist in education or untangling that. And that might seem for sort of the audience that we have, it may be pretty straightforward. You may think, oh, that's very obvious. But I think when you're thinking about a large organization, different, leadership and administrators involved, that can be an educational process. So, that has come up, and Crystal will kind of go through this as well, when you're thinking about what are the potential options as far as I'm going to keep ownership of this, I'm going to optimize it, we're going to keep this all in-house, or we're looking for other alternatives, we're looking for partners to come in and help us run it or take it off our hands. It's really important to understand that inpatient and outpatient are different than outreach. So when we think about outreach, we're thinking about community, like specimens, testing, business that's coming from the community. It's coming from non-patients and non-patient encounters. So that would be community physicians, facilities that aren't part of the institution, but something that's sort of like within the footprint, typically within the footprint of the institution, and the hospital is pulling it from there. And then inpatient and outpatient, of course, are registered patients. So it's testing volume and services that are coming from registered patients. And I think the thing that's challenging is the outpatient and the outreach. That always, like, folks struggle with that. So did you want to add something to that?
I was going to say, I think that's the biggest part. Yeah. So we actually had a client who had commingled, we'll use the word, but not inappropriately, the way that they tracked their data, back to the data management, the way that they tracked their data is the outpatient and the outreach revenue was coupled together, and we couldn't pull it apart from a legal perspective, which is why we need a group like HC1 to come in and actually be able to track the various streams of revenue. And so what ended up happening is the letter of intent proposed by the buyer took into consideration both the outpatient and the outreach for purposes of the letter of intent and their purchase price bid. Once they got in and started doing due diligence on the healthcare system and where the revenue came from for the particular lab, they realized that the buyer had overstated the purchase price based on the revenue multiple that they wanted to apply. And so we got all the way through a letter of intent, we got all the way into due diligence, and we ended up with a significant purchase price reduction because of this distinction. And so I had to bring in Liz. We had to have this big, long conversation about the various streams of revenue. But now we're back to, we're just the lawyers. We can only identify the issue, but we don't actually have the capability to go into the systems and pull out the data to figure out how do you divide up the revenue that is actually being sold versus what is being kept in-house. And so that was kind of one of our big war stories for purposes of thinking about, well, how does data management actually flow through an M&A transaction? And this would be probably the number one thing, which is purchase price. What are you actually buying?
Oh, I'm sorry. I was just going to add, I mean, I think the other confusing part, which I didn't touch on, is just the provider-based, like facilities or institutions that have provider-based locations. Like, is it a physician office? Is it not? Is it a physician that's part of the organization? Is it not? Well, in those cases, it is. And in those cases, the organizations for provider-based clinics, they're considering those encounters as part of the hospital. You're going in there, you're getting charged a facility fee as a patient. Maybe you've noticed that, because that office or clinic is considered part of the hospital. It's a department, it's an outpatient department of the hospital. So that is another place where, again, it's a matter of data management, information management, and not every organization has that primed when they go into thinking about these things. So that's important. Yeah.
So the provider-based thing actually just came up with one of our clients. So it's not just about data management, but it's also billing vendors, using the appropriate billing vendors who actually understand place of service for provider-based versus physician clinics. We are working with a pretty large pathology group that has a relationship with a really large health system, and the health system was trying to get them to bill their encounters differently. And I'm not going to go into the legal, like all of that, but basically the hospital wanted them to use a more advantageous place of service for the hospital, even though it didn't comply with the provider-based billing rules. And so it was a giant mess. And then to Liz's other point, like, we had to get on the phone with hospital counsel and explain to them what it means to be provider-based and why you have provider-based clinics and how you bill for provider-based locations. So it can be a complicated situation.
All right. So next topic. I'm keeping the mic. Okay. So next topic would be another place where we see the data management piece flow through an M&A transaction is on the net working capital adjustment. If I had to pick the number one post-closing dispute item that I see in healthcare transactions, it is over net working capital. And what I mean by that is in every M&A deal that we have worked on, there is usually a commitment by the seller to deliver to the buyer, and the buyer is requiring a certain level of net working capital at closing. Usually it's based on an average amount of net working capital that they typically receive. So that is, in an M&A transaction, usually current assets minus current liabilities. And your current assets are your AR, your accounts receivable, and your inventory. So we're back to supply chain management. And the buyer will say, all right, I want target net working capital to be delivered at closing equal to X. And there's usually a post-closing true-up such that if you did not deliver X net working capital at closing, there is a purchase price adjustment. The problem is that there's the concept of, garbage in, garbage out. If you don't actually know how you calculated the target, and you calculated the target based on faulty numbers, post-closing, you end up having an adjustment to the purchase price. Usually, as you can imagine, the buyer has the most leverage in this situation. It is the buyer finding out that your account receivable wasn't good, your inventory management wasn't good, and you didn't have enough usable inventory on hand at closing. And so you find yourself in a situation where, as the seller, your data management policies for purposes of the net working capital calculation were faulty, and therefore post-closing, there's a degradation in the value that you delivered, and now you have to give some of the money back. So that is another place where we see this management of your information flow through the M&A deal. The second most common dispute situation we find is around breaches of the data privacy reps. And so what 10 years ago was a one-paragraph provision in a purchase agreement, it is now a 2-page provision in our purchase agreements relating to How do you manage data? Are you HIPAA compliant? And what happens if, there was a pre-closing breach or even a post-closing breach relating to your data policies? So this is where I'm going to turn it over to Emily to talk a little bit about some of the things that we look at in due diligence relating to data privacy and thinking about how do we mitigate risk for our clients when they go to sell their lab.
Yeah, so I think the purchase agreements are the first place where we started to see this expanded version of a data privacy rep. Better? Do you want me to wave too? I'm kidding. So to Crystal's point, it was like a 3-sentence paragraph, and now it is 2 pages. And the rep is, do you have HIPAA policies and procedures? Are you updating them? Do you have a security officer? Do you have a compliance officer? Have you had a breach within the last usually 6 years, depending on what the look back period is? If you did you report it? Are you doing a risk assessment? Are you doing penetration testing? Like literally everything that you can think of. And then are you complying with state law, layer in CCPA, GDPR, all of these things? And it becomes oftentimes a hotly negotiated portion of the contract. We've had breaches come up during the diligence process. We had one lab that was hit with ransomware. And they didn't really want to do anything about it until after the deal closed. And we were like, yeah, you can't do that. We have to report it. So and the reason they had that breach was because they had really crappy policies and procedures and safeguards in place. So that drove down the valuation because now there was this liability associated with notifying a ton of patients, potential class actions, regulatory investigations that last for years. I handle most of our firm's OCR investigations, which is what happens when you have a large HIPAA breach. The government moves at a snail's pace. I think we all know that, but I still have investigations open from like 2017 that OCR hasn't closed. So it is not a timely process, and you're talking about like holdover potential liability and escrow situations. And then the other thing we see, do you want me to talk about the data rights issues that we see too? So in the diligence process, one of the things that we do as attorneys is go through pretty much line by line all of your contracts to see what they say. With data rights, it is who has the data, who have you given ownership to? Do you really own the data? And we have seen that in multiple deals completely blow up a deal because there's been a dispute over who actually has access and ownership of the data. So these are the things to start thinking about now to make sure, not even from an M&A perspective, but just from a compliance and best practices standpoint, to make sure you are operating your business as compliantly as possible.
I would agree. And I think the thing and the way we approach diligence, and I appreciate Brad saying, like, we're not trying to be the deal prevention squad. What we're actually trying to do is think about what are the risks? Can we mitigate them on the front end? And then if we're representing the seller in this particular instance, how do we go to the buyer with a plan? Because most M&A transactions, in my experience, there's usually some sort of solve. It's better to disclose, you gotta confess, you've got to bring it up, but you can do it in a way that shows that you are prepared to handle the situation. No one wants a data breach, no one invites it, but if you're prepared for it and it happens, you can say, all right, we had a data breach, but here are the things we had in place and these were the steps that we took. And most of the time, there is a way to negotiate with the buyer, either some sort of purchase price adjustment. Maybe there isn't even that. Maybe it's just an escrow. Maybe it is coming up with a plan of attack for purposes of dealing with it post-closing. So just because a situation or a diligence item occurs or we find something out, it doesn't mean that you can't do the deal. What happens is if you try to sweep it under the rug, it ends up exploding and becoming a lot larger of an issue. And so with big healthcare systems, understanding what actually exists becomes very important, not just from a financial standpoint, but from a legal perspective, because you can actually start to figure out who the people are you need to help you get to a place where you can present to a buyer the best possible version of your business. No business is perfect, but best possible business that you can show. Anything you want to add?
I guess I was just going to say, I mean, like there is such a level of partnership that I think before we did as much before I got as involved in M&A, I didn't appreciate, sort of the succession and the collaboration that has to happen in a transition. So the other thing here is, to Crystal's point and Emily's point, if you have to be sort of a good citizen as you're going through the deal, right? Because you're keeping that trust. You want to maintain that trust. You don't want to undermine the trust or the working relationship. So that's all part of, having a handle on your information, your assets, your data, and then also, really being on top of it and being willing to work through issues when they come up and meeting them head on, right? Like not sweeping them under the rug.
No, I would agree, because I think that applies then to the post-closing integration, which is where your legal but also your consultants can help with that as well, because now you've done the homework, you understand your own business, you've now sold it, but it doesn't just end there. The purchase agreement is actually the easiest document to negotiate. One of the hardest documents to negotiate is the transition services agreement, and finding a way to uncouple your LIS and all of your systems and connect it to your buyer's system. And you're back to data management, garbage in, garbage out. So if you don't have a good handle on your information, it's hard to connect it to a buyer's information. And what we have often found is if a client sells and they don't have that totally under control, it's really important to work with someone who can help with that connection process, because otherwise you end up in a situation where you cannot respond. You can't do the collaboration that Liz was talking about because you just don't have the information. And it makes the transition process go a lot longer and exposes you to potential more legal liability, because inevitably you are going to unknowingly breach your transition services agreement.
Well, thank you all for being here for another episode of Boombostic Health in the Wild. It was great having so many featured speakers for this important event as we're here in Indy for the Healthcare Innovation Summit. We'll see you next week.